Hi everyone, my name is Joie Chiu, and today I'll be presenting my public health case study on the 2009 H1N1 pandemic. The 2009 H1N1 virus, also known as the swine flu, was a novel strain of influenza A that spread rapidly around the world. The problem existed because this virus was completely new to humans, meaning there was no pre-existing immunity, and it was highly contagious through respiratory droplets. The outbreak began in Mexico and the US in spring 2009 and spread to 214 countries, leading the World Health Organization to declare a global pandemic by June of that year. In terms of demographics, the virus affected mostly children, young adults, and pregnant women, which was unusual compared to typical flu seasons. In the US alone, there were around 61 million cases and about 12,000 deaths. This widespread impact highlighted serious gaps in pandemic preparedness and communication. When public health agencies began developing a response, they had to consider several key factors. Economically, there was the cost of vaccine development and distribution on a national scale. Socially, the public's attitude and trust in health authorities play a huge role. Vaccine hesitancy and misinformation created challenges in reaching herd immunity. Infrastructure was another issue. Hospital capacity, laboratory testing, and health workforce availability all influence how quickly cases could be identified and treated. Looking at the SWOT analysis, the main strength was the rapid scientific response and vaccine development within just a few months. The weakness was limited vaccine supply and delays in distributing doses to high-risk populations. An opportunity arose to improve national pandemic preparedness for the future, and the biggest threat was misinformation and fear, which reduced public compliance with vaccination and preventive measures. Now, let's look at the root causes behind these challenges. The primary cause was that this was a novel virus, so no one had built up immunity. There was also delayed detection early on, which allowed the virus to spread before control measures could be implemented. Other key issues included limited early vaccine availability, public misinformation, and a general lack of preparedness. The two main core problems were first, high transmissibility, leading to rapid global spread, and second, limited vaccine access, especially for vulnerable populations. However, these challenges also created an opportunity to strengthen pandemic preparedness for future outbreaks, improve public health communication, and ensure equitable vaccine distribution strategies worldwide. Now, let's discuss the solution implemented and theoretical perspectives. The main solutions during the 2009 H1N1 response included mass vaccination campaigns, hygiene guidance, mask wearing, and in some areas, school closures. Public health messaging through media and schools play a key role in raising awareness. From a theoretical standpoint, both the health belief model and the social ecological model can explain how these strategies worked. The HBM focused on educating people about their susceptibility, emphasizing the severity of the illness, and promoting the benefits of vaccination while reducing barriers. The SEM, on the other hand, addressed multiple levels, from individual behavior change to family and community influence, to policy-level interventions like school closures and vaccine funding. In addition to the official response, there were other possible solutions. One alternative would have been to set up mobile vaccination clinics in underserved areas, ensuring better access for rural and low-income populations. Another alternative could involve legal policies, such as mandatory case reporting or school vaccination requirements to control spread. Peer-reviewed research also suggested that targeted outreach in schools and workplaces could increase vaccination rates. Using the social ecological model, these approaches address factors from individual decision-making to broader policy changes. The social benefits of such strategies include protecting vulnerable groups, reducing hospital burdens, and building long-term community trust in public health systems. Based on all this analysis, I have a few key recommendations for the future. First, we should focus on stockpiling vaccines to maintain sufficient supply for future outbreaks. Second, there needs to be early and consistent public health messaging through schools, social media, and news outlets to reduce misinformation. Third, ensuring equitable vaccines access, especially for high-risk population, is critical. Lastly, I recommended establishing permanent pandemic preparedness units within organizations like the CDC and WHO. These units could train local health departments on rapid response and coordination. Here's a timeline for an action plan that combines legal and public health strategies. Step 1, 1 year. Draft new public health policies for vaccination, school closures, and case reporting. Responsible groups include CDC and state health departments. Step 2, 6 months. Secure funding for vaccine production and public education campaigns. Responsible groups include CDC and state governments. Step 3, 6 months. Launch national education campaigns on vaccinations and hygiene. Responsible groups include CDC and local health departments. Step 4, 1 year. Implement policies nationwide. Enforce mandatory case reporting. Promote vaccination guidance in schools and workplaces. Responsible groups include CDC, local government, and legal authorities. Step 5, 2 years. Monitor compliance and evaluate effectiveness through ongoing surveillances. Responsible groups include CDC, state health departments, and WHO. This step-by-step structure ensures both legal accountability and public health efficiency. In conclusion, the U.S. response to the 2009 H1N1 pandemic was effective in reducing mortality, but it also faced clear challenges with vaccine distribution and communication. When compared to other countries, Canada relied more on primary care for vaccinations, resulting in fewer school closures, while Japan emphasized early mass use and strong community cooperation, which lower infection rates. The key lesson here is that timely vaccine access and transparent communication are crucial to managing pandemics effectively. In my opinion, the U.S. must continue strengthening preparedness plans and improving public trust through transparent communication. By integrating social engagement with science-based policy, we can build stronger resilience against future pandemics. Thank you.